Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, everyone, and welcome to VITALS, Visionary Health Leadership in Action. I'm Dr. Forrest Faison, the Provost of the Northeast Ohio Medical University, and I'm filling in today for President Langell, who sends his regrets. VITALS is NeoMed's Health Leadership Series, done in partnership and in collaboration with the university hospitals. It's an opportunity to meet with our nation's transformational healthcare leaders who are using the tools of VITALS, vision, innovation, technology, advocacy, leadership, and service to transform and improve health and healthcare for our communities and our leaders. Today, we're privileged and blessed to be joined by Dr. Airica Steed, who is the first woman, the first person of color, and the first nurse to lead and be the CEO of the MetroHealth healthcare system. Dr. Steed's accomplishments are enormous and would take up the entire hour to present today. But I will tell you, she is the epitome and personification of both servant leadership and community-focused leadership. Under her leadership, MetroHealth has grown to a $2 billion a year operation serving the needs of Cleveland and Northeast Ohio, which it has done as its mission since 1837. She is making a difference. Her focus on community care, eliminating disparities in healthcare, reducing the gap in healthcare services, and improving health and healthcare outcomes and wellness for all people have really set her apart for leaders. She's been recognized numerous times by many different organizations for her leadership, her visionary impact, and the differences that she is making in communities wherever she is at. She has a doctorate degree in education, in ethical leadership, a bachelor's of nursing, as well as a master's in business administration and numerous certifications and accreditations. And never satisfied, she's currently in a master's program at Harvard for global engagement. Dr. Steed, it is a privilege and honor to welcome you to VITALS today.
Thank you so much. Thank you. Thank you so much. Can you hear me? So thank you, Dr. Faison, and thank you so much to Northeast Ohio Medical University for inviting me here today. And thank you, administration, faculty, staff, students, alumni, friends, and supporters of NeoMed. What a true honor it is to be here today and to be a part of the VITALS Leadership Series. Eight years ago, I was pregnant. One morning, I woke up with an eerie feeling. I was knocking at death's door. I can absolutely feel it from every stretch of my being. As I rode in the ambulance, drifting in and out of consciousness, I was certain, truly certain, that I was transitioning out of this life. my life was over. I had been diagnosed with preeclampsia, the pregnancy-related condition that is 60% more likely to strike and kill women of color. I was an educated woman, a nurse, a fourth-generation nurse, a healthcare executive, and I knew the symptoms of preeclampsia. And when I experienced them, I raised my hand and I tried to speak up. And guess what? My concerns were dismissed. Like so many Black and brown patients, my worries were ignored, my pain was diminished, and my voice was muted. So much so that I began questioning myself and my voice. I didn't get the attention that I needed until I was in the emergency department fighting for my life. My daughter was born early, weighing just 1.5 pounds, and she spent 4 difficult months in the neonatal intensive care unit before we can bring her home. My daughter is healthy today, and I am here today. And I can honestly tell you that I'm here today only by the grace of God. Millions of moms and babies of color have not been so fortunate. Black and brown women are 3 times more likely than other women to die from pregnancy-related causes. From 2018 to 2021, the maternal mortality rate of Black women in America rose an unbelievable 87%. Right now, a woman of color in America is more likely to die before, during, or after childbirth than the average American woman was in 1965. But America's maternal mortality crisis is just one example of a much wider crisis of health inequity. With almost every serious health issue out there, people of color have been dealt both a tragic hand and a short stick, whether it's diabetes, heart disease, hypertension, cancer, stroke, kidney disease, Alzheimer's, HIV, mental illness, addiction, or any one of the dozens of other issues. People of color suffer more, suffer longer, and they die sooner than others. I know this firsthand. I've witnessed it. And I can honestly tell you that I've witnessed this not just with my own suffering and from my own example. The most beloved people in my life were dealt this tragic hand and this short stick. They suffered more, they suffered longer, and they died way too soon. My mother was also a nurse. She dedicated herself and her career to a healthcare system that tragically took her life away. She passed away when she was just 46 years old, and I was 23 years old on the front row seat. I watched the horrors of misdiagnosis, the horrors of delayed care, and the horrors of mistreatment. Fast forward, both of my grandmothers also died too soon. Both of them died from breast cancer. My maternal grandmother was misdiagnosed twice, and by the time her cancer was discovered, it spread to her liver, her kidneys, her brain, and her bones. And my baby sister didn't even reach her 40th birthday. At the age of 36, knowing our family's history, my baby sister asked for a mammogram. She begged for a mammogram. It was denied. 3 years later, she tragically died from breast cancer. And had she not been denied this basic screening, had she not been pushed away, had her voice not been muted, I'm confident that my baby sister would be here with us today. And I know this with the highest degree of confidence. So I asked this question: how many lives and how much time has been stolen from us, from our families, and from our friends? Research tells us that just in the last 2 decades, communities of color have experienced 1.6 million excess deaths compared to other populations. Health inequities have caused 80 million years of lost lives. 80 million years. That's 80 million years of lost time with friends and family. 80 million years of lost music and art. 80 million years of lost scientific innovation. And 80 million years of lost contributions to our communities. The monetary cost of health disparities to our society has been estimated conservatively at $250 billion per year. I am asked all the time, and I mean all the time, whether America's healthcare system is ready for the next pandemic. And the answer is we have not even dealt with our centuries-old pandemic of health inequity and health injustice. And this pandemic has 2 strains. The first strain is America's broken healthcare system. And this system has long failed to serve, failed to listen to, failed to provide the access, the care, and the outcomes that our vulnerable and underserved children, women, and men deserve. If individuals do interact with this broken system, there's a good chance that they'll interact with people who don't look like them, who don't understand them, who haven't walked a day in their shoes. And it's no surprise that distrust remains very high among the very people who need our care and services the most. So fixing this system, this broken American healthcare system, means that we must expand access to care by widening our front doors and our back doors to our communities, by going deep into our community, and by connecting and serving the patients where they live, where they work, where they learn, where they play, where they age, and where they worship. Fixing this broken American healthcare system means that we must take necessary steps to improve representation of our providers so that they mirror the beautiful tapestry of the communities that we serve. And we know that patients do much better when they have a provider who looks like them. They have much better outcomes, and research proves this time and time again. They are more likely to show up at their appointments. They are more likely to take their medications properly. They are more likely to get life-saving screenings and tests. Fixing this broken American healthcare system means that we must listen intently and intentionally to all of our community's needs. We must listen intently and intentionally to all of our community's ideas and embrace their suggestions. And we must offer a seat at the table for our community to be a part of the solution. And that we have a responsibility to act on what we learn. We have a responsibility also to come down from our silos, and there are many. There are absolutely many silos that is destructive in this American healthcare system. We need to come down from our silos. We need to check our egos at the door. We need to partner directly with our community, and we need to build up trust that has been fractured for centuries. And it means also creating programs and initiatives that are laser focused on solving inequities and not sweeping them under the rug. And solving those inequities requires that we must get out of our comfort zone of the four walls of hospital systems, because the answer to inequity lives outside those four walls. More than 80% of what we can impact on health equity lives out in our communities. But America's broken healthcare system is just one strain of the pandemic of health inequity. And it accounts for only less than 20% of our problems. The other strain is much deeper. It is more destructive. It is more dangerous. It is rooted in centuries of inequity and centuries of injustice in America. These are the social factors that determine a person's health. And we know them as the social determinants or the social drivers of health. Let's talk about two people living in Greater Cleveland. A person in an affluent suburb in Greater Cleveland, and a person living in the more urban Buckeye Woodhill neighborhood of the city. They might be living in the same county, in the same city, but they're living in two completely different worlds. The person in the suburbs went to excellent suburban schools and has a college degree, something that 83% of Cleveland residents do not have. They have a good, stable job that provides a household income about 3 times the $30,000 median income of Cleveland households. Their suburb has a poverty rate just shy of 3%, while Cleveland's poverty rate is 10 times higher. Almost a third of Cleveland's adults and almost half of Cleveland's children live in poverty. Let that sink in for a moment. Half of Cleveland's children live in poverty. Half of them. The person in the suburbs lives in a home free of mold, free of asbestos, free of lead, a home that is affordable for their family. And across the border in Cleveland proper, almost 90% of the housing stock, 90%, was built before lead paint was banned in 1978. And almost 80% of adults are living in unaffordable housing, which means that they're spending 30% or more of their income for just a roof over their heads. The person in the suburbs wakes up to the sound of birds. They have a fully stocked refrigerator and they don't have to want for food. And their home internet hums along at a high speed they want for nothing. And just a few miles away, in the case of Bracknell in Glenville, a bridge away. In Cleveland's 5th Ward, residents wake up to sirens. And 80% of them qualify for food bank benefits, and 40% of their homes have no internet. These two worlds take a real and tragic toll on the health of individuals. On average, the person in the suburbs is 33% less likely to have asthma than their friend in the city. They are 20% less likely to have high blood pressure. They're 21% less likely to die from heart disease. They're 39% less likely to die of a stroke. They're 45% less likely to have diabetes, and 87% less likely to be diagnosed with HIV. This person from the suburbs can also expect, on average, to live more than 20 years longer than the person their age, their same age, living just a few miles away in the Buckeye Woodhill neighborhood. That's a 20-year death gap. 20 years. Underserved, overlooked, disinvested communities are disproportionately impacted and disproportionately damaged by virtually every health and human services issue out there. And I have to repeat that, health and human services issue, because this is not just a healthcare problem. This is a larger problem. This is about humanity. Every health and human services issue out there, from asthma and heart disease to maternal and infant death, to mental illness, to gun violence and incarceration. In the suburbs, the children try to go to Yale. In Greater Cleveland, in the urban areas, the children try to stay out of jail. Enough about the problems if I have not demonstrated a proper business case for why it's so imperative that we must destruct and destroy and eradicate healthcare disparities and inequity. Let's talk about the solutions. How can we end the pandemic of health injustice and health inequity? We must attack both strains, the broken American healthcare system, and at the same time, we need to reverse the tragic social drivers of health, and they're plentiful. So how do we do that exactly? First of all, we must realize that we absolutely can do this. It's easy to throw up our hands and say that these problems are just overwhelming. They're just too big. They're just too intimidating. It's just easy to give up and believe the illusion that these problems are just going to go away and solve themselves. They're going to go away on their own. I can honestly tell you from my own personal experiences that this is not the way things are supposed to be. Health inequities, health disparities, and health injustice, and the social factors that fuel them were never acceptable. They are not acceptable now, and they will never be acceptable. Cleveland is not supposed to have 50% of its children living in poverty. Not 40%, not 30%, not 20%, or 10%. No child should ever have to grow up in poverty. So who created this pandemic? People and institutions and policies created them. And that means that people and institutions and policies can dismantle them. And I believe that this is all of our calling, every single one of us. So this is a call to action more than anything else, because we all have a vital role in this vital work. Every single one of us, at every age, of every race, in every sector. And I think that we prove to ourselves and we prove to everyone else that we are leaders by embracing this work, because it's absolutely necessary. No single person, institution, organization, sector, or policy created these pandemics. So no single person, institution, sector, or policy can fix them. It is going to require a great deal of collaboration and partnership, true partnership. And it's going to require all of us to get out of our own way, to really come together and galvanize together on one collective agenda. Just like we did with the COVID pandemic. This is going to mean breaking down silos. This is going to mean eliminating lanes and widening the road. It will mean breaking away from our four walls of comfort. And I believe, and I truly believe, that our generation will be judged by how well we fix, how well we eradicate these injustices around us. The injustices right under our noses, in front of our eyes. And I'm talking about the poverty. I'm talking about the violence. I'm talking about the suffering. I'm talking about the tragedy that plays over and over and over again in my mind every single day. I never forget the loss of my mother. I never forget it. This is not volunteer work. We will all be paid in full. And the pay and benefits from this work will be unimaginable. There will be enormous benefits to our local economy, to our community's health and well-being, and to our region's standing in the nation and around the world. We are on this planet just a short time, and I know this to be true from my few experiences of knocking on death's door. I know we're only here for a short time. And while we're here, ending health injustice must be our calling. And after what I've experienced, and after what I've witnessed personally and professionally, I know that that is why I'm up here today. This is the reason why my life was salvaged, and I know that. I found my purpose, and I hope each of you find your purpose too. And I know that while I'm here for this short period of time, that I have to do whatever it takes to turn around this ship. I absolutely refuse to allow the Titanic ship to sink. I absolutely refuse. So this is my calling, and I hope that you realize that this is your calling too. So thank you so much. It is now my great honor to welcome to the stage one of my treasured friends and one of the state's most respected, trusted, and accomplished broadcast journalists. Please join me in welcoming the legendary Monica Robbins.
You knocked my shoes off.
Oh, I knocked your shoes off your feet.
She did. Thank you so much. I can tell you just from, we have almost 145 people watching on Zoom.
Oh.
And we've been getting a number of messages of how powerful your talk has been. And I know the folks here in the audience are feeling the same. I feel like we're at war. You know, and I know a number of these folks who are going to be graduating on Saturday have a lot to think about. I want to encourage all of you here in the audience, if you have questions for Dr. Steed, we have microphones on either side. Please step up to the microphone and we'll call on you and you can ask a question. And for our Zoom audience, feel free to put a question in the Q&A section and I will ask. And we do have our first question from LaShawn. So this question is, how do you plan to fix health disparity, such as adopting communities? And how do you implement that initiative?
So number one, I love the question. When you think about our ambitious goals around health equity, it is overwhelming. It is monumental. And my goals are very bold. And I don't wince or blink an eye when I make statements like eradicate health disparities and zero out the death gap, because I'm serious when I make those movements in that direction. Just because for me, one life lost is a loss too many, and I wish I can just wave that magic wand and get my mother back through the health and injustice and health inequity that I've experienced. But the way in which we attack and eradicate, we have to laser focus and take bite-sized pieces as opposed to boiling the ocean. And I gave some examples of the differences in communities, just in our neighborhoods. And I can honestly tell you, you can go a 5-mile distance and just crossing some bridges, 20 years of your life is lost. So I think that what we need to do is really laser focused on those communities that have been historically disinvested, historically muted, historically disengaged, historically not heard. And historically, those needs simply have not been met. And one piece at a time is the way in which you do that. But we have to really step aside as one organization, one individual, because we can't be naive to expect one organization and one individual to really solve for that. So really the sense and spirit of community means that we're all going to have to rally together around that particular community. So what community-based organizations, what faith-based organizations, what healthcare organizations are in that particular community so we can rise up together? And this is going to require investing in both the health care needs. So most certainly there are a lot of nuts that we need to crack on ensuring that we have the programs, ensuring that we have the accessibility, ensuring that we have the representation on the healthcare side, but that's only part of the equation. We're also going to have to invest in those social drivers of health. So by adopting a neighborhood or adopting a community, we're going to have to invest in ensuring that there is stable, affordable housing that's free of all of those environmental factors that takes us back and causes healthcare issues. So we need to address for the housing. We need to address for the transportation, because I can assure you that if a particular individual that is living in poverty, they're given a choice of keeping their lights on and feeding their child who is already starving because they were born in poverty, and paying gas to put in a vehicle that they cannot even afford, and likely they don't already have that vehicle. They're going to choose keeping their lights on and putting food in that child's mouth, as opposed to caring for themselves and caring for their healthcare needs. So we're going to have to address the transportation issues and barriers. We're going to have to ensure that there's digital connectivity in that home so we can find creative and innovative ways for accessibility and for you to interact with the healthcare system. So we're going to have to solve for all of those problems collectively. But I believe that attacking one community at a time gets us closer and closer and closer to our goals, as opposed to trying to boil the ocean.
Makes a lot of sense. We have a question here.
Thank you, Monica. My name is Amy Lee. I am our Master Public Health Program Director here at Northeast Ohio Medical University. And Dr. Steed, I just want to thank you for your talk. I want to thank you for being a leader, to be a relentless champion for health equity in our Northeast Ohio area. My question is, and I'm hoping it's on behalf of our Master Public Health students, but as future graduates or young public health professionals, how can they best collaborate with our hospital systems such as MetroHealth to be able to achieve health equity? How should they partner with you, and what could they do as coming from public health?
Well, number one, I love the question, and I think that the key is in the word that you just used, partnership. And I think that we have so many great ideas and so many great intentions. And unfortunately, I think that what we've created is a lot of unintentional silos where we're not coming together, we're not partnering together for the common good, and we're not galvanizing around one common agenda. So I think that we need to understand how to properly partner, right? And that means stepping aside and saying, I'm not representing my one organization right now. I'm representing the community. So how do we all get behind in one room and try to problem solve together? I think that is absolutely key. But also from a MPH point of view, my goodness, health equity is a public health problem. It is a public health crisis. And this is a learning lab for MPH students. My goodness, I would open up the doors wide open at MetroHealth. There's so many different learning opportunities that you can experience and really, really integrate into your program, real world problems, solving for the violence, solving for the over incarceration, solving for the over boarding of our emergency departments. And we've seen an uptick in the number of mental illness and addiction issues that are coming through the doors of our emergency departments that unfortunately translate into over incarceration. So there's a multitude of public health issues that are real, that are experiential learning opportunities for your students to really flourish and really get at the ground floor level, that we completely will open our doors for those experiences. Also, I would fully promote on-the-job internships and fellowships of MPH students, so you can transition directly, immediately upon graduation into careers where you're making a difference real time. So we can actually co-create a MPH experiential learning program, internship program for the MPH students, that we can incorporate a real world solving real world problems real time as part of that internship or fellowship. But I have plentiful ideas on how we can make that work and how we can truly come alive on the word partnership.
Thank you. We would truly love that.
Yeah.
I'll have the same question for all of the medical students who are graduating and going into their residency. And for those who are watching, their eyes are now wide open.
Mhm.
What advice do you have for them?
Oh, my goodness. So I would say, take the message that was extended today as a call to action. I most certainly can say, just being a nurse by profession, that this work truly is a calling, and we have a big problem to solve. So while you're in this particular wonderful profession, how do you drive how do you come to your purpose in this particular profession? So I think that we can all contribute to solving for the great challenge of eradicating the health equity pandemic. So I would say truly get engaged and lean in and jump in above and beyond whatever the role that you intend to engage in. I think that there's a bigger difference that you can make by getting engaged, asking the right questions, rolling up your sleeves, getting into the trenches, and truly bringing the community in and asking the community, how can the community help shape you as a professional as you go about your own personal and professional journey?
Would that same answer apply to this person who says, what small steps can medical providers, doctors and APP do in our own practices to make a difference?
I would say this, intentional listening has been the centerpiece of my entire leadership style. And you learn a lot when you just take a couple steps back and do more listening than you do talking. And I think it's important that for all professionals, regardless of whatever their discipline, to really take a couple steps back and help to unlock the voice of the community. So empowering the community to find their voice, empowering the community to advocate for themselves, listening differently. Just because I think that spoken word it comes in different shapes and sizes. And there has been so much pent up distrust in the community at large. And I can honestly tell you, from being a professional, being a nurse by training, I was trained to be a nurse, and witnessing the horror and the tragedies in my own life, I built up a wall, a sense of distrust, where I didn't want to interact with the healthcare system. I avoided the healthcare system because I was let down so much. What I would encourage any discipline, any level of professional to do, is to listen intently, not to the physical wounds that present themselves in the community at large, and in that person, in that resident or individual that is in front of you. Start to teach yourself to be able to identify the wounds that you cannot see. And the wounds that you cannot see is that built up distrust, that built up sense of letdown, that built up sense of hopelessness, that built up sense of despair, that built up sense of, my gosh, what's the point of even raising my voice if I'm not going to be properly heard? And there's a lot of individuals out there like that. So I think that this goes above and beyond the classic training. This really requires a sense of human kindness, a sense of human spirit that oftentimes it just takes real lived experiences to be able to navigate through that. And I can honestly tell you, it took multiple times over in multiple interactions in the right person to get me out of my own shell. Just because I was tragic, it was tragic for me, and the level of post-traumatic stress disorder that I've experienced to really build up the fractured sense of trust that I had with the healthcare system. It took work, and it takes a special person to really do that.
Do you think cultural education in medical school and nursing school would be a wise idea?
Yeah, I strongly believe in all levels of cultural competency, cultural education, cultural building, and all of that. I strongly believe in that, but I don't believe you can train away human unkindness. I don't believe that you can actually do that. So I think that at a foundational level, I think that everyone should be trained at a foundational level. But what I would encourage is for anyone in any discipline or any profession that you're in to step outside your comfort zone and train yourself to be uncomfortable and comfortable in very different circumstances that's outside of your norm. So I would say, if you grew up in that suburb that I was describing, and that's what you're accustomed to, that's what you're used to, I encourage you to experience what it's like in Buckeye. I encourage you to experience what it's like in Glenville, and just sit in the waiting room for a moment and just witness what the differences are. And having that real world perspective, having that sense of empathy, having that sense of stepping in someone's shoes is eye-opening. And I think that can teach you better than a cultural competency training. And I'm not against training and learning, trust me. I'm working on my second master's degree. I'm a lifelong learner. So I'm just saying, because I know we're in an educational facility, but you can't replace a lived experience. You can't replace it. And that's all the training that you need to understand what triggers you, right? What builds up that sense of urgency and that burning platform is realness, just reality, a reality shock, right? So I don't know how many individuals have ever experienced an individual in their life that died tragically due to the horrors of just being let down by a system that is supposed to be the best in the world, right? It gives you a perspective like no other.
We have a question?
Hi, Dr. Steed. First, thank you for your inspirational talk. It's really been great to listen to you. I'm assuming that we don't have the luxury to wait around for a mayor or a governor or a president to help us through this. What can the grassroots do to start moving the needle?
We need to be the mayor, the president, the governor on our own. We need to be the president, the mayor, the governor of health and equity. So we need to take the bull by the horn. If anything is a takeaway from today is we don't have the essence of time. We don't have a runway. That runway is gone. And I would argue that, and I'm screaming at the top of my lungs on this, the sense of urgency, the response that we received from COVID, we need that level of sense of urgency right now, right here and now. And I can unpack a multitude of challenges that we're suffering from right now, but we have a multitude of pandemics happening every single day, all day long, in every single neighborhood across this country right now, that requires the same level of reaction and the same level of response. So grassroots organizations, what I would recommend in its entirety is grassroots organizations not go about this individually. Figure out your peer grassroots organizations. Let's get in a room together and let's not just have a conversation, because the business case has been proven. Now is the time for action. Now is the time for action. And now is the time for us to call a spade a spade. This is unacceptable. It's tragic. And I can honestly tell you, maternal infant mortality rates right here in Northeast Ohio is worse than some third world countries. It's worse. So when is that going to result in us saying enough is enough? Our moms and babies should not die senselessly and tragically. So we need to be the mayor. We need to be the governor. We need to be the senator. We need to be the president of the United States on this issue. And then we need to do it all over again because we have many issues that we need to solve for.
The grassroots effort might tie into this next question. How do we as healthcare professionals and leaders sustain the resources and efforts being made to bring justice, to provide equitable and humane care and services?
We spent $3 trillion on senseless death. So I think we have the resources. We have the resources. We just need to stop wasting the resources. So I strongly believe, and I'm encouraged, and I'm very optimistic that the solution is right here in front of us. Solution is right here in front of us. And I can tell you one of the many draws and many reasons why I came to Northeast Ohio and I was attracted to MetroHealth is because we're a zebra. We're an organization that turns down no one, regardless of their circumstances, regardless of their means, regardless of their ability to pay, and we still do it. $250 million worth of uncompensated charity care was just spent just last year. And we're going to continue on that path, regardless of whether it's sustainable or not, just because I'm constantly, every single day, my role is to build the plane and fly it at the same time. That's my role. But also, I would say it's unacceptable for us to spend senseless dollars right now, just wasted, just because we refuse to figure it out. So if we turn the tide in what we're wasting, I think sustainability is not even a question. Is truly a sustainable solution right here before us. Collaboration, partnership, engaging the community directly, unmuting the community's voices, attacking the social drivers of health, investing the right resources in disinvested areas. And I can honestly tell you, if I can choose two social drivers that I would invest in first, it will be education and poverty, because those two things determine how long you're going to live, not a healthcare related issue. It's those two things. And I can honestly tell you that it does not cost the dollars that we're wasting to solve for those two challenges.
On that note as well, this person says we need to admit more students of color into nursing and health professional schools. How do we help these students succeed?
So I think the first things first, I think that we need to go further upstream, and I think that we need to convince and plant the seeds early in the future generation of healthcare professionals. For me, I was extremely fortunate. I knew at birth who I was going to be. I knew at birth. I'm a fourth generation nurse. It was born from my great grandmother, who was a nurse midwife well before nursing schools were in order. But I can honestly tell you, growing up in my household, it was no other option. Nursing was it. I think we need to do that for our future generation. And it starts with our children, right? I think that we need to go into preschool and kindergarten and show these children what they're made of, and show them what the potential is. And honestly, where I get encouraged and what really gets me motivated and hyped up is, if you can see it, you can be it. And I'm extremely proud and I'm extremely fortunate to be the first nurse, first female, first person of color to lead this storied institution after 200 years, but it's also my responsibility to ensure that I'm not the last person. And I'm always leaning down, allowing others to climb on my shoulders to get into the profession. But we need to blanket ourselves into all of the schools, beginning in preschool. And I think we need to go further upstream. And even as moms and daddies are talking to their unborn children in their womb, they need to start sending some encouragement that you can be whatever you want to be in that womb, so you can plant that seed early for it to blossom. But I think one powerful example, and I think a good example also lives on this campus at NeoMed, is the high school concept, where we can start to train up and upskill and build those bridges, build that pipeline. At MetroHealth, we have the first and only high school in a hospital across the United States. And we have a pivotal opportunity to graduate students into professions and graduate students into the bridge, into those professions early. And I think that is going to be the answer. Let's go further upstream. Let's plant the seed. Let's water, let's water, let's water, let's water. Let's encourage, let's motivate, let's inspire, and the world is going to be a different place.
One more question.
Thank you. Attending the American Delivery Film Festival, featured film. It was wonderful. If any of you have seen it, and I know the strong hand that Metro had in that, and because I know the strong history of Metro, and so proud to be part of some of the stuff that's been done there, that I'd like to see if you could talk a little bit about some of the things that Metro is doing for maternity health in this space. Thank you.
Thank you so much. American Delivery is a project of the heart that I'm extremely proud of, and I'm especially proud of MetroHealth featuring in that documentary. American Delivery really centers around nurse-centered solutions to attack and address the maternal infant mortality crisis that is pervasive across our communities, but it also sheds a glaring light on the reality that the United States has gotten fundamentally worse on those statistics as opposed to some other countries, even third world countries. But in and of itself, there are a few areas of promotion that we're really encouraging. One is the Nurse Family Partnership Program that MetroHealth really centers around, which actually partners up a nurse with mom and baby up to 2 years of life to really focus on holistic care, not just healthcare needs, but really addressing those social drivers of health. So if there are transportation issues, if there are food insecurity issues, if there are mental health issues that really need to be addressed, the Nurse Family Partnership Program has wonderful outcomes that are proven. We just want to ultimately scale that program throughout all communities, so every single woman and their child can actually benefit from that. Also, we're encouraging a promotion of the use of nurse midwifery, and it can certainly be in a team-based approach in concert with your physician. But most certainly in comparing and contrasting positive health outcomes in some other countries, it's found that nurse midwifery programs in coordination with other downstream programs are proven to really address that. And the state of California has demonstrated significant outcomes on that. And then lastly, a doula program, which is a emotional support mechanism that we can tool up and pair up with moms throughout her pregnancy process, which has proven to have substantial health outcomes associated with it as well. But I'm extremely proud of American Delivery. This is only the beginning. So we just launched it in Northeast Ohio, Cleveland proper. It just won the highest award at the Cleveland International Film Festival. So the sky is the limit in terms of our possibilities of really taking that message and really nationalizing it. I can honestly also tell you, hot off the presses, I used American Delivery as a vessel for some critical conversations with our legislators. I was on the Hill really fighting for advocacy and policy changes around ensuring that we ensure that those mechanisms are consistently placed in the forefront of our mind as we continue to crack the nut on solving the maternal infant mortality crisis. So thank you.
Dr. Steed, you're so insightful, so inspirational, so incredible. Thank you so much. And I can't wait to watch you work more.
Oh my
So
gosh, thank you so much.
Speaking of legendary.
Thank you all so much, Monica. Thank you.
Thank you.
Lose my thing here.
Oh, we're sharing
I
microphones.
think so. Dr. Steed, Monica, thank you all so much. To our visitors here today and to those watching online, thank you for joining us as well. There's much work to do, but much great opportunity to make a difference. Please join us next month on June 6th for our next Vital Sign. Thank you again, and everyone, have a great day. Thank you.
This is VITALS, Visionary Health Leadership in Action.